Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen in Germany, and I would like to show you results from 6 interesting studies which were published in July 2022. Let me start with epilepsy and pregnancy. You are all aware that some of the anti-epileptic drugs are teratogenic, in particular valproic acid. But anti-epileptics during pregnancy can also cause autism or intellectual disability. And this was now investigated in a huge database in Scandinavia in 4.5 million pregnancies. And the follow-up was 8 years after birth. Now, the authors compared more than 20,000 children where the mothers had epilepsy but did not take anti-epileptic drugs during pregnancy, and the same number of children where the mother took anti-epileptic drugs during pregnancy. And the study showed that the risk of autism and intellectual disturbances at age 8 years old was significantly higher if the mother took either valproic acid or topiramate. And this means that most probably these 2 drugs should be avoided if possible during pregnancy. There was also a dose relationship, so higher doses of these 2 anti-epileptic drugs had a higher risk to cause or to be associated with autism and intellectual disability. The next study comes from intensive care medicine. It's a study which investigated high-dose vitamin C in patients with sepsis on an intensive care unit. There were prior studies which had different outcomes. And this study recruited 872 patients with sepsis, and they either received vitamin C 50 milligrams per kilogram body weight every 6 hours for 96 hours or placebo. The study was not only negative for vitamin C, it showed that vitamin C had a higher risk for the primary endpoint, which was death or organ failure. And mortality was significantly higher on high-dose vitamin C, and this means this is the end of vitamin C for the treatment of sepsis. We have new guidelines of the European Headache Federation on the use of monoclonal antibodies for the prevention of migraine. I do not agree with the first conclusion, which is that these monoclonal antibodies should be first choice, not because they are effective and they have very few adverse events, simply for cost reasons. And most healthcare systems will not reimburse monoclonal antibodies as first choice. They give advice on how long to treat, and the usual advice is to treat for 12 to 18 months and then pause medication and see what happens. And they also indicate that most probably if one of the monoclonal antibodies, for example erenumab, is not effective, then it makes sense to switch to one of the other ones, galcanezumab, eptinezumab, or fremanezumab. Another interesting study looked at triggers for migraine attacks. I think we all believe in the concept of triggers, and we advise our patients to avoid them. Now, this study investigated 328 patients with an app, and they recorded their migraine attacks, but on a daily basis, they could also record 38 possible trigger factors. And the result is astonishing. On average, this study identified only 2 trigger factors per patient in 90 days. And the most frequent ones were neck pain and sleep disturbances and anxiety. And this means that we have really to think hard about whether we still advise patients to avoid trigger factors. The next study comes from Sweden. And this is a study in remitting multiple sclerosis. Scandinavian countries use rituximab, a drug which works via B cells, very frequently. Now, the drug is not approved for a simple reason. It went off patent before studies were done on this drug. And this study now compares rituximab 1000 milligrams initially with 500 milligrams every 6 months in patients with MS and compares it with dimethyl fumarate oral 240 milligrams twice daily. The recurrence rate of new MS recurrences in the next 24 months was 3% on rituximab and 16% of fumarate. Now, whether the positive results of this study would lead to rituximab being reimbursed by the healthcare system, I'm not sure. The last study is the most controversial one. This study investigated ultra-high doses of vitamin B12 in patients with early stages of amyotrophic lateral sclerosis. This was a study from Japan, double-blind, placebo-controlled for a treatment period of 12 weeks. They found that the intramuscular injection of 50 milligrams vitamin B12 twice daily for 16 weeks led to a significant benefit in ALS patients compared to placebo. But most experts say they don't believe the results. There are two major problems. One is the short treatment period of 16 weeks, and the more serious problem is that high-dose vitamin B12 will color urine, and in this way patients are no longer blinded. So most experts at the moment would not use high-dose vitamin B12 in patients with ALS. Dear colleagues, ladies and gentlemen, I am Christoph Diener from the University of Duisburg, Essen in Germany. I presented you with hopefully 6 interesting new studies. Thank you very much for listening and watching.